Our project is about the management of diabetes. It's been known for a number of years that if you intensively focus on diabetes management, you can reduce blood sugar levels, you can reduce the onset of complications or at least delay them. There are two ways to do that. One is low tech and the other is high tech. And our project essentially is to look at whether there's any benefit to doing the high-tech way as opposed to the low-tech. The low-tech is multiple daily insulin injections, might be 3, 4, 5 injections a day of standard syringes with bottles. The high-tech solution is an insulin pump, which is obviously a sophisticated piece of equipment and fairly expensive. We know either technique can be used in a motivated patient to get the blood sugar down. The question is whether there's any benefit to going high-tech as opposed to low-tech. What's becoming very apparent is that insulin pumps are far more enabling of independence, making the person able to travel, vary the timing of their meals, vary the timing of their exercise, participate in church or work activities or family activities. They become much more independent of their diabetes than they are in comparison with the multiple daily insulin injections. Both techniques allow them to control their diabetes effectively. What we're talking about is the accoutrements of getting that job done and whether or not it intrudes upon or interferes with getting on in your life. So it's not saying that
one is better than the other in the sense of
they both can work if they're done right with the right supervision and the right motivation. The Medicare regulations for payment for an insulin pump are a blood sugar less than 225 milligrams per deciliter and a C-peptide, which is a form of insulin byproduct, that is within 110% of the lower limit of normal of a C-peptide. What that effectively does is eliminate type 2 diabetes. So current Medicare regulations restrict the use of the pump for practical purposes to type 1. Medicaid, Georgia Medicaid, at least in terms of where I work, follows Medicare guidelines. Private insurers are variable, but in terms of Medicare and Medicaid, essentially the pump has been restricted to be used in type 1 diabetes. But the benefits have been shown by us and by others to be applicable to either type of diabetes and also at any age, because of course Medicare kicks in at retirement age.
Sure.
So the vast majority of diabetic patients out there who have the potential to benefit from this technology, according to current regulations, are ineligible unless they've got enough cash to pay for it by themselves. First of all, I hope we're going to increase awareness that this technology is useful and can be used in both type 1 and type 2 diabetes. And then hopefully as that information becomes understood and replicated and supported, that those who are responsible for looking at guidelines for coverage will be able to reconsider. Essentially, it's the age-old problem of whether the upfront high investment really does get paid off by the long-term benefit. And what we're trying to point out is, number one, that it does, and number two, that the large segment of the diabetes population that is type 2 should be eligible for it as well. So we're hoping our research will lead to a rediscussion and reconsideration of those eligibility criteria.